Welcome to Building My Legacy podcast. This podcast is designed for leaders and entrepreneurs who want to leave a legacy and will provide strategies that focus upon key elements for legacy creation, determining your desired impact and its benefit, increasing your legacy's reach by engaging key stakeholders, planning, prioritizing, and executing. Here's your host, Dr. Lois Sonstegard.
Welcome, everybody, to today's Building My Legacy podcast. I have with me today Shane Foss, who is CEO of Hooray Health. I love that name. I think if we could look at healthcare and say hooray instead of, oh my, what did I get? That would be a perfect positive change, wouldn't it? So he has over 20 years of tenure as an executive in the medical industry. He got started because he was frustrated with how underserved Americans were being treated in terms of getting their healthcare needs met. So he set out to look for, is there a way we can deal with really meeting the needs of the underserved population? He comes with a strong background in healthcare. He has partnered with companies like Sedera, Emeritus, Aflac. So he has a tremendous amount of backbone behind him in terms of what he has looked at and done. So Shane, from here, I'm going to turn it over to you. You can tell the audience about how you got started and what the purpose is behind what you're doing, why it's needed.
Oh, well, thank you, Laura. I really appreciate it. I'm excited to be here. Yeah, it's been a journey. So we were talking earlier, I grew up in northern Minnesota in a small town called Cloquet, and was able to, the Air Force let me in for some reason, I don't know, and became a surgical technologist. And that was my entry into healthcare. And I've never left. Absolutely love it. Been in had multiple roles. Whether it was, a clinical role or in sales with large medical device companies. But, it's something that I never get bored of. Absolutely love it. And, very thankful that I've been here. But, it's interesting when you look a few years ago, we were getting ready to sell a company, and we had basically created access for large self-funded employers to surgical bundles. And that was really my first entry into really understanding how healthcare is purchased and how it's paid for. And it's there's no correlation between cost and quality today in healthcare, and it's just absolutely insane. But what was interesting was we served the population that was insured. And so when we sold and I was looking at opportunities, I had this idea as I was consulting, and my back went out, and I went into an urgent care, and I had United Healthcare at the time, and it was a $75 copay for urgent care, so I paid it, and then I asked them, hey, what can I just pay the whole amount now because I haven't hit my deductible yet? And they said, oh, it's $150. I said, okay, great. So I paid it. I went in, they took an X-ray of my neck. They found a little bone spur that was irritating my nerve root. And then they gave me an injection with an anti-inflammatory, and then another injection for a anti-inflammatory, and then the other one was a pain relief and muscle relaxer. That's what it was. And so go home, didn't really help, but I go home 3 weeks later, I get an $800 balance bill. So I call them up and I said, hey, I paid you the full amount. This was the contracted rate. Well, we had carve outs. And, the ugly truth today, what happens is, pricing transparency is in healthcare, as everybody knows, is crazy. But, since Obamacare or the ACA, a lot of contracts now, because the high deductibles have come into play, right? So if you have a $3,000, $3,500 deductible, a lot of the contracts now, they'll have a bunch of carve outs and they'll allow you to bill more. Well, how are you supposed to know? And you don't. And so that gave me the idea that, there's this huge underserved population right now that continues to grow that's uninsured. That's the hourly, whether it's hourly full-time or hourly part-time. And so I went out and I put a business plan together, and I went out and I built a national network of retail clinics and urgent cares that accepts a $25 prepay as payment in full. And then they accept our payment, and that's it. No balance bill, and it's in my contract. And so we protect the members. And this hourly population, they need short-term financial stability. Forget long-term. They're looking at short-term. How do I get from paycheck to paycheck? How do I take care of myself? How do I go to work, not get everybody else the flu? How do I get my kid in for their wellness exam, and if they're sick, and pay for it? And I think it's really scary what's going on today, because people are foregoing healthcare, going to a doctor when they're sick, and little things become big things, and it's devastating. So that was my goal.
So when you talk about having a low copay when you go to urgent care or to a clinic, $25, what do you do with people who have underlying conditions? Diabetes, for example, chronic hypertension.
Yeah, when you've got, so like if it's hypertension, you can go in to see a physician on your wellness and get your prescriptions. But when you have diabetes, it's a much more serious condition. We are not major medical, and we're not trying to be. Okay. We cover everyday urgent and urgent, basic and urgent healthcare needs, and we are we're what you call a fixed indemnity and an accident policy that really acts as one, and we basically allow you to go when you're sick, when you're even if you're pregnant, to go in for your checkups, but we'll pay. But it's the idea is really giving the member access to affordable care, right? Which is what they don't have today.
Right.
And when you look at under the age of 45, the average person, American, goes to see the doctor 1.9 times a year, right? And so it's hospitalization really comes in later in life, and and the majority of our members are under 50.
Got it. So do you have age cutoffs in what you're doing right now? Like Kaiser Permanente, when they first started, they had a target population. They didn't go outside that. It was one of the things for which they were criticized for, actually, because it was really skimming the cream more than anything. But,
sure.
So how have you managed that in terms of your population? Because you're fairly new, so you've got to have stability and be able to plan financially.
So we have our ages. We work with a couple carriers, and so we can go 18 to 85. And so really, it's interesting is you wouldn't think 85 would be important, but we have a couple clients where, in large retail setting, you'll have a good part of their full-time or their part-time force that's retired. And so our benefits actually help them tremendously as well. So it's great. So we're not skimming any cream.
Got it. So tell me, as an employer, what would I pay for an individual plan for my part-time people, for example?
Probably on average about $75
per person per month.
Per month, yep.
That's amazing.
Yeah, and so the goal is, again, we're very pragmatic. We're not trying to, I think part of the challenge, especially as a startup, you don't want to boil the ocean, right? The cliche. You want to make sure that you're addressing what the real need is, and the real need is, when we talk to employers, they say, "I'm sending our employee home because they're obviously sick, and we don't want them to get the rest of the team sick." And we say, "Go to the doctor," and they're like, "I can't afford to go to the doctor." And so what do? They go home, and then they've got to wait it out for a few days instead of getting medication. Right. And so so we're really we're trying to just improve access. You get access for $0 cost for telemedicine with us, unlimited. We have 24/7 medical concierge you can call, and there's a medical professional on the other end of the line that can guide you. They'll triage you and guide you wherever you need to go. We have a mobile app that centralizes all of our benefits. We're really unusual in this space because there's other companies that have offered a product there, but they've never addressed the issue, which is full access to affordable care, and that's what we do. That's our primary focus. This is all we do every day.
So will you talk a little bit about bankruptcies, the number of bankruptcies that follow a health event? And I know of many, having been in the healthcare field.
Yeah.
Particularly in, as you look at NICU babies and and other things relative to cancer care. What's your experience, and how does this really help prevent that?
So what most people don't realize is that 1 in 5 Americans are sent to collections every year for a unpaid medical bill, less than $600. So the NICU babies and the cancer, that's not what everybody's getting sent to collections for. It's I'm going to get my back went out, I went into the urgent care, and I get an $800 balance bill, and I'm getting sent to collections for that $800. And so that's how we address that. So by being able to go in with a predictable payment of $25 and knowing that there's not going to be a balance bill on the backside of that, we're really giving that member comfort that they can go in, get the care that they need for that illness. And that's what's important. I mean, we really take a pragmatic approach, because if you look at cancer, which is a very scary word, you're looking at less than a 0.25% that get cancer under the age of 45. We don't address that. And it's just, so everything we do is statistically managed. We look at everything statistically. Why are people going to the doctor? The reason we have the accident policy is under the age of 45, 60% of your claims dollars are accident related, right? My daughter, she's on the soccer pitch and she breaks her wrist because she fell down, right? Or, playing basketball, breaks a finger or breaks an ankle. So the reason we do that is because we want to cover them, because that, one broken wrist can turn into a $3,000 bill like that. Well, we pay 100% of it. We pay up to $5,000, $0 deductible. And the reason we do that is because, again, the most common things that happen, and that's what we're really protecting.
So you partner with larger insurer companies. So if I were Target, for example, I could have Aflac for my major medical, and then for part-time, for people who need to pick up the pieces for the episodic care, we would have you in addition. Is that how that works? Yeah.
So somebody like a Target, since you're using them as an example, they would be self-funded. And so they use, I don't know who they use, but let's just say they use United, and they self-fund. Well, then with us, they would use Hooray. They would offer Hooray to their part-timers, and then the part-timers then would have access to a fully insured product through us. Whether, and some of our carriers that we use are, be Access. Access is an A-rated carrier that underwrites our product. So, so that's how.
But what you're really getting around, Shane, is that high deductible.
Correct.
What you offer, right? So
the cost and the high deductible. Correct.
Got it. So what do you see right now? We've had a huge push. Well, we have it off and on. It depends on the political cycle, I think, for a single payer system. Your thoughts on that and your experience with that in terms of what you see happening to the quality of healthcare and the cost.
Yeah. So first of all, I think that, it's an oxymoron to, just talk about cost quality in the government, right? So why anybody would think that would change is beyond. But if you look in England, if you look in Canada, it really is still a two-tier system. You have insured. Yes, everybody's covered on the national health plan, but if you want to get in to see a physician quick, it just doesn't happen. And there's other things that can happen for us that I think are important before a single payer system. I just we're not addressing the cost issue, which is really the issue at hand. Why has hospital costs gone up 3,000% since Obamacare came in? We're not addressing those issues, and until we address those issues, I don't think they're a single payer, whether it's a single payer or not, it's not going to work.
So it's interesting that you talk about that in terms of hospital care, right? What did you say the percentage increase was?
3,000.
3,000% increase.
Yeah. So
go ahead.
Oh no, go ahead. I'm sorry.
So one of the trends that I see happening is there are groups that are going outside the hospital now saying, let's contain it. A, we can have a lower infection rate by not being in the hospital. But two, I can actually know what's happening cost-wise. I can give now my patients a bill. So what do you see happening in terms of these trends that are going to be emerging or are emerging right now?
Yeah, I think the best trend I see is lots of independent physician groups that are they have surgery centers. They're coordinating care in a bundle situation where you have anesthesia, the surgeon, the implants, the facility, the rehab, everything bundled together. That coordinated effort and that care is really important anyway. But I think what it does too is it allows for cost containment. And what we saw at my last role with Employer Direct was, we saw a 50 to 60% reduction in cost by, one payment going to a single entity that managed that. So I think what you're going to see there's a really good group, Oklahoma Surgery Center up in Oklahoma City, that does a great job with this. And you have pricing laid out and it says, $16,000 for an ACL surgery. And that's it. You write a check for $16,000, you're done. And so I think that those trends are really exciting and look forward to them continuing to grow. The challenge is it's still, it's a have and have not, right? And so we're not addressing the issues from an equality standpoint of care, because not everybody can go, afford to do that. So. Right. But that's exciting. I think that's a good trend.
So, right now, the whole issue of equality is huge in every single area, isn't it? We're looking at the social unrest because of inequality. And interestingly, healthcare has not entered that discussion currently in terms of inequality, but it does exist. And so as you look at that, you come from an area where we were talking earlier in terms of Medicaid dollars being state matched to federal dollars, right?
Yeah.
And you have a state that has had a lower interest in providing those services. And so, so you have a disproportionate availability because of a state choice. But yet we look at this as a federally mandated or a federal problem in terms of, in terms of healthcare, and maybe the blessing of the discussion we're having with what's happening with police is finally we realize you just can't leave it to the state. We need some standards that are federal standards that apply. Perhaps, I don't know. I'm just throwing it out there. But we have a disproportionate way of states looking at what you're going to provide. So how do you create equality?
Yeah, that's a great question. I really, I don't know. I really don't. It's a huge issue that I don't know enough about from the Medicaid side of the house. I do know that it's a fallacy to think that everybody's got access, whether you have money or not, right? Because we know that firsthand. That's just not the case. And so, there needs to be a change. Whether that's in Washington at the state level. The other thing is there's such a difference in literacy and priorities, and so when you put it all together, it's a very complex problem. It's just very complex.
Right. If you could wave a magic wand, Shane, and do one thing that would really impact healthcare, what would that be?
Base everything off Medicare, and that I think that would be the
Medicare pricing you're speaking.
I'm sorry. Yes, Medicare
services that are available through Medicare.
So I think, every service is available pretty much, except for, even plastic surgery is listed.
No, so be available through Medicare.
Yeah,
Medicaid, but not Medicare.
Well, yeah. So Medicare, yeah. So the reason I would do that is, and a lot of people that are listening are probably like, well, it already is. Well, it really isn't. But being able to show and limit your ability to bill 300-400 times Medicare would be I think my magic wand would be. That's what we should have a standard, which in most people's eyes is Medicare rates, but the reality is it really isn't. And so I think that creating Medicare rates, and hey, it's, if you hit, we're 120% of Medicare. We're 130%, not 3, 4, 5% of Medicare. And that in my mind would help a lot. That would be the quick fix. And then hospitals and everybody have to kind of reorganize, because most physicians, that's what they operate at anyway, to be honest with you. It's the hospitals that are the ones that would have to reorganize cost structure to be, make money at that rate.
There are so many things, Shane, and our time goes much too fast when we're talking about a topic like this. There's so much that really we need to think through. And in my mind, yes, it's complicated, and yet it's not so complicated either. I've worked in Texas where, I've dealt with the Medicaid, lack of Medicaid provisions. I've dealt with Minnesota, which is almost the reverse. We have a lot that we make available, right? It's sort of the two ends of a continuum. And yet in neither system does it work really well. And we have I think, citizenry that's growing more and more discontented with what is available with healthcare. So I just really applaud what you've done. I mean, most people, when they start a project with the healthcare, do not start with the underserved.
Yeah.
And, and it's huge. The other thing that we haven't talked about today that I think is so important is rural healthcare. They are part of the underserved population.
Right.
But I think more and more they're being discounted, left behind, not thought through carefully in terms of what their needs are. You have a large rural area in Texas. What's your experience and thought on that?
Yeah, so telemedicine, I think, is first and foremost. I think one of the big trends that you'll see, especially now over the course of the next 5 years, is more primary care going to telemedicine services, which is for me incredibly exciting. I think that's, being able to use the technology, and there's so many aspects that we don't even understand, every day, that your scale, your heart rate monitor, your blood pressure cuff can be attached to your phone, to where that can send that information to the telemedicine provider. So I think from a rural standpoint, that's a great start. I think the other part is, we see a lot of urgent cares opening up in the rural areas that we're contracting with, which is great. And when you look, the whole idea with us going with urgent cares was the acuity of care that they provide is fantastic. You can get an IV, you can get stitches, you can get an X-ray, you get on-site labs, you can get your basic care. So it's, urgent cares, I think, are, they're here to stay, but I think they're the hidden gem in American medicine today, because they're one of the few groups that actually are transparent with their pricing. And so, yeah. And so from a rural standpoint, we, as a matter of fact, we have a farm in Woodville, Texas, way out in the middle of nowhere. And we have a Walmart, and now we have an urgent care. So
interesting. Because the urgent care is part of Walmart. It's part of
no, it's just right next to it. But again, I think that physicians are seeing the need to get out of that 9 to 5 day in and day out and get to the 8 to 8 p.m. and offer a larger offering for these people. And so, so I think that's where we're going on the rural side in my mind.
Super. Before we leave, I just want to go back to one other comment that you made, and that is the importance of having something available for part-time people. And you were sharing something earlier about what happened with COVID, and suddenly some of big retailers discovered with their part-timers they weren't going to get health care or to be evaluated or checked because they had no healthcare insurance, so they weren't using telemed. You want to just share a little bit about that before we close?
Yeah, absolutely. So COVID for us was an eye-opener in the sense that we started getting calls from large restaurant chains and retailers right away, because they realized that, oh my goodness, they don't even have access to telemedicine. And what happened was during this COVID, which nobody's really talking about, is physician offices didn't say, "Hey, come into the office to get tested." They were like, "No, go away, right? We don't want you in our office right now. If you think you have COVID, stay home. And then if you need to go get tested, then you'll go in through one of the government, drive-throughs." And so people, people that don't have access to telemedicine, they were like, "What do we do?" And so that was a real challenge. That was an eye-opener. And so when you look at these, especially these large retailers that have hundreds of thousands of part-timers that didn't have access, now all of a sudden it's like, well, shoot, man, we really need to reconsider that. And so I think COVID has really brought it to the forefront. I think it's great. Look, all these companies, they're very maternalistic with their people. They're not bad. It's not at all. I mean, I think how they're villainized, I think it's just, is it a priority? And so I think their priorities have really been questioned in the sense that, hey, we really do need to do something. And so, it's been really exciting for us, and we're happy for all the part-timers that we're able to help now.
It's wonderful. Shane, thank you so much for this time. And this whole discussion is so huge. There's so much that we really need to think through and to talk about as a country for, and it's really, what do each of us as individuals want to consume? That's what we want to create for people. And in a way, that's what you've done by looking at the underserved. You looked at what is it that they need in order to have what others have, and how do we make it more equitable across the board. And that whole piece of equity, we do need to come back to and revisit much more aggressively, I think. Thank you so much for your time. And everybody,
thank you for having me.
You are so welcome. Everybody listening to Building My Legacy podcast today, thank you for being with us. And we will get you information about this and future podcasts shortly. Thank you very much.
You've been listening to Building My Legacy podcast with Dr. Lois Sonstagard. To book your appointment with Dr. Sonstagard, visit www.buildtomorrow.com.